We have Dr. Bob Gillespie, who I've known for over 25 years, a good colleague, friend, and expert in the area of guidelines for hypertension. I think often, you know, at Sharp, we're always so busy with it, we don't even know the expertise that we have even in our four walls. But truly, Dr. Gillespie has been very involved beyond his busy clinical practice with crafting guidelines. And guidelines are what really do help shape our practice. But I think where guidelines can sometimes be limited is where Dr. Gillespie is trying to help us. And that is, there can be subgroups within, let's say, the population of people with hypertension. And we all know as clinicians, they don't all necessarily should be treated the same. So with that introduction, Dr. Gillespie is going to help us learn today how to use our guidelines that he's helped craft to manage our patients. Thank you, Bob.
Thank you, Brian. And I have to say, Brian, you've been a wonderful colleague, and I look forward to spending the next few years working with you. Thanks again. Hypertension guidelines. Again, hypertension is one of those topics that we often overlook because in cardiology we have so many other things that we do. You know, we have the patient with coronary disease, we have the heart failure patient, we have the AFib patient. So people say, why would you have an interest in hypertension? Because everything I just mentioned to you goes back to hypertension. I titled this More Than Just a Number because many of you, if you follow the media, you know that there's been a big discussion about targets and blood pressure, controversy. This guideline, however, goes well beyond that number, and I hope I can share that with you today. I have no disclosures as it relates to hypertension. My objective today is, first of all, to give you a historical perspective on how we got where we are now. Why did we have the controversy in hypertension? Let's talk about masked hypertension as well as patients that have sustained hypertension and white coat syndrome. I want us to look at the blood pressure targets and how we should make a determination on how to treat our patients, and to not overlook the more important things that we often do, and that's the lifestyle modification and how we really have to apply that when it comes to treatment of hypertension, even beyond picking the correct drug. How do we evaluate the appropriate patient to put on 2 therapies instead of 1 at the very beginning of onset of hypertension? And we'll talk about specific treatment modalities for conditions as time will allow, because this is a very large topic, as you will soon see. I want to ask anyone in the audience, can anyone identify the people in this picture? Go ahead, anyone's.
Roosevelt, Churchill, and Stalin.
Okay, why did I put this slide up? Where was this meeting when the 3 of them were together?
Yalta.
Yalta, 1945. Which of these men died of hypertensive stroke? All 3 of them. Which of these men had emergent crisis for hypertension? FDR did. FDR, before he died, his blood pressure was 300 over 190. Churchill's doctor, 2 weeks at Yalta before he died, said he looks like he's near death. What medications was he on? Nothing. So this is 1945. Where have we come with hypertension? One of the things back in the mid-40s, and even all the way up to the mid-80s, there was this attitude that hypertension was something that was normal if your blood pressure was 100 plus your age. So if your systolic blood pressure was 180, you're probably fine if you're 80 years of age. Even despite all the data that was accumulated, the National Heart Act was enacted in June of 1948 during Truman's administration. That led to the Framingham studies that eventually showed that patients that had hypertension had a multifold increased risk in developing coronary disease. So this was something that we knew, but the attitudes about hypertension didn't change until much later. We still know that by the 1970s, we were still treating systolic blood pressure as if it was not a major problem. If you look at the guidelines between J and C1, the first of which was in 1977, up until JNC7 in 2003, you'll see a gradual change in the guidelines numbers for hypertension. Okay, so what you'll see here is there's a gradual change. Initially, we focused on diastolic blood pressure, but over time it became very clear that blood pressure required more aggressive treatment. And by 1991 or so, this is when the systolic blood pressure in elderly study came out in 1991, we started to look at systolic blood pressure, but up until then, we ignored systolic blood pressure for the most part. But as time went on, we started to lower our guidelines to include blood pressures at 130/80 in those patients that were at higher risk. And this is where we have our dilemma, because with JNC8, this is when the whole issue came out about whether or not we should be less aggressive in patients with blood pressures in the range of 150/90 and over the age of 60. This committee, which eventually, by the way, was disbanded by the NHLBI and told to work with the various societies, they made a decision to go ahead and publish the data that they had already worked on, though they were instructed specifically to not do that. When this came out, it became controversial because their recommendation was age greater than 60 years, blood pressure go 150/90, unless you had diabetes and chronic kidney disease. Several members on that committee, however, were concerned about that guideline. And because if you look at the data in patients that have coronary disease, if you're over the age of 65, your incidence of disease is 1,000 per 100,000 patients, where under 65 it's only 30. Stroke, the same thing, very high incidence, low incidence under 65. So when I saw this data, I was concerned when the guidelines were being changed. Jackson Wright, who happens to be a nephrologist and a good friend, had some significant concerns. He was on that guideline committee. He, as well as Dr. Ogadabi, decided they had to speak out. This article was published in Annals of Internal Medicine, and they showed their concerns about that decision. Later, I was fortunate enough to be involved with this guideline evaluation that was published in JACC that talked about our concerns, particularly as it relates to women and African Americans and how it might impact if we made this change. So a number of series of articles came out. We then came to 2017, and that's what we'll be talking about today. The guidelines that are currently present to address hypertension. I want to point out that Sid Smith, who was here with Brian and others for years, many of you remember him, was on this committee, as well as the initial JNC8 panel. Now, many of you already understand this and deal with classes and strength of recommendation, but those of you who may not, I'll quickly go through this. As we go through the guidelines, remember when you think of strength of recommendation, you're looking at benefit versus risk. So if you have a very strong recommendation, that's class 1. If it caused harm, it's class 3. Level of quality of evidence is, when you talk about quality, you're looking at the quality of the data that's present. So if it's a strong randomized clinical trial, so if you have multiple clinical trials here, you can see that the data is very strong. That would be a level of A, all the way down to expert opinion, level C. I'm not going to spend a lot of time just showing you numbers because that can be quite tedious. But I do want you to understand this process. But also remember, expert consensus does not mean that it's bad data, it's bad information. It just means that we may not have all the data available because the clinical trial hasn't been done. So don't ignore those class C recommendations. I'm having trouble turning this off. Good. Before we get to blood pressure measurements, I want to make sure that when we measure blood pressure, that we do it the correct way. And that's part of our problem. The biggest issues that we have, quite often, patients are running into the office, either the doctor's running late or the patient's running late. You sit them down, you're talking to them, you check their blood pressure. When they sit down in the middle, I'm just going to put this down. You sit down and the blood pressure is high. You expect it to be high because and if you make a clinical decision based on that, that's a mistake. Many of us make that mistake in our practices. We aren't checking blood pressure correctly. And as you will see shortly, that's why it's important to check it outside the office also. Make sure the patient's feet has to be on the ground. Give them 5 minutes. If the blood pressure is high, you have to check it again. And by guidelines, you should average those two. But at the very least, check the blood pressure multiple times before you make a decision that there's truly hypertension. Make certain that there is the correct size cuff. you have a big arm and a small cuff, you're going to get blood pressure that's falsely elevated. These all seem like minor things, but we make clinical decisions on wrong data. We don't do that when we take patients to the cath lab or when we do other things in medicine. We certainly don't want to do it for hypertension. I want to point out, which I meant to say earlier, that 1 in 3 Americans has hypertension. If you're lucky enough to be 45 and not have hypertension and you make it to 80, you have over an 80% chance of developing hypertension. That means 8 out of 10 of us is likely to have this. So we should have an interest in making this done the right way. We should have an interest in hypertension. There were 4 questions that the committee asked. I'm going to go through each question, and we'll talk about each one. The first question was, what about home assessment? Is it in some way going to be beneficial? Is better control acquired through this mechanism? Is better control when you check patients at home versus in the office? The answer is yes, you do get better control. All of our patients, based on a class 1, level of evidence A, should have home blood pressure measurements. Every single one of them when there's concern about blood pressure, for all the reasons we just talked about. This article was published after the guidelines in New England Journal a few months ago. A Spanish study looking at 64,000 patients for 10 years. And what they did is they looked at white coat syndrome, which was defined as hypertension in the physician's office, and blood pressure that's normal at home, masked hypertension, M-A-S-K-E-D, which is very important, with hypertension outside of the office but normal in the office. You can imagine that could be a troublesome group of patients that we may not detect. And the third group is sustained hypertension, where blood pressure is high both in the office and as an outpatient. This study had a good percentage of men and women, as you can see. It was shown that using ambulatory blood pressure readings, an ambulatory blood pressure is where you have a prescription, the patient wears a blood pressure cuff, it checks the blood pressure every 15 minutes to 1 hour during the day and less during the night, showed that using that had about a 50% better predictive value as it relates to outcomes, cardiovascular mortality. Even more shocking, though, is when you look at masked hypertension, the one where the blood pressure is high outside of the office and normal in the office, which makes up about 15% of patients that have ambulatory blood pressure readings, your risk ratio was 2.8, almost 3 times greater risk of cardiac mortality if you miss that condition.
Okay,
yes.
What causes that? I mean, white coat, we think the
right.
patient's nervous, he's run into the office, but what would cause?
You know, it's such a...
Is he like relaxed that he's in a healthcare environment and his blood pressure goes down?
I don't think we know, Brian. That's just it. It's a very confusing process, but it's real. It's a real phenomenon.
I don't doubt it. Yeah.
And don't know exactly why. Maybe stress at home, you're getting away from home, I don't know. but either way, it happens. And sustained hypertension and white coat syndrome both have significant risk to the patient. So we shouldn't ignore even our white coat syndrome patients. Now, this data with the white coat syndrome is different and depending on what study you look at, but keep in mind we should monitor these patients. I'm not going to go through all of this. I want to make 2 points as it relates to white coat syndrome. First of all, if you make a decision not to treat, often we do that. A patient comes to our office, the blood pressure's high, we just say, oh, you know, this is just because they're rushing for all the things. We shouldn't just leave it at that. Make sure that patient checks at home. That was a 2B recommendation, 2A, B level of evidence recommendation. Another group of patients, if you are concerned about white coat syndrome based on the numbers that they have given you at home, it's normal in the office, high in the office, but at home they're noticing that it's normal. You might want to confirm that with an automated blood pressure cuff because sometimes it's not correct the way patients are checking it, et cetera. By the way, CMS does pay for it's $52 they'll pay for using an ambulatory blood pressure monitor. Not a lot of money, but it is something. I wanted to get to the topic of masked hypertension since this is the group that has the highest risk of poor outcome that we talked about in that Spanish study and other studies. If you're checking blood pressure that's mildly elevated in the office and the blood pressures are, let's say in the 120 to 129 range, those patients are at risk for having masked hypertension. That might be a group you're missing, so they should check their blood pressures with their own system at home. Bring that blood pressure cuff in to you to verify that the numbers are accurate. The last thing I want to bring up is if you have target organ damage, you have an echocardiogram with unexpected LVH, the eye exam shows nicking or something else that's concerning, kidney disease, creatinine's elevated, and you don't know why. You want to screen that patient possibly for masked hypertension. Not a lot of data out there to support that, but consensus is C, so it is felt strongly by this guideline committee that we should look at those patients. What was the second question? What is the optimal blood pressure target? How do we get there? This is where all of the controversy has come in terms of targeting blood pressure. Before we get to drug therapy, we have to understand the most important thing that we can do for our patients is not pharmacologic therapy. It's treating them with non-pharmacologic therapies instead. We know that it's hard to believe, but if you look at the number of patients that the weight loss in itself, you can, for every kilogram that you lose a millimeter, you drop by 1 millimeter blood pressure. So if you can get a patient to lose 5 or 10 pounds, you can get a significant drop in hypertension. DASH diet, that's just a diet high in vegetables and fruits and beans and grains, not having a lot of meat in the diet, also a substantial drop in blood pressure. In this study, about 11 millimeter drop in blood pressure. And we'll go into what makes up some of the dietary changes you can make that are simple. Dietary sodium is crucial. I know there's always controversy about sodium. In the United States, about 90% of us consume over 2,300 milligrams of sodium. The guidelines is we should be below 2,300. If you have heart failure, of course, even less, 1,500. Optimally, you want to be at 1,500 even for hypertension. This is a big one that I'll get back to shortly. This is an easy intervention, and that's increasing potassium intake, which can lower blood pressure quite substantially. Exercise we know is important. It's not only exercise is important to prevent coronary disease, but also hypertension. They kind of go hand in hand. You can see the substantial drop in blood pressure with different types of exercise and minimizing alcohol intake to no more than 1 or 2 drinks a day. Women, no more than 1. Sorry, ladies. 1 a day. Men, 2. Now, it's hard to get patients to drop down below 1,500 milligrams of sodium. But one thing you can do, this study that was just published last year, at the end of last year, looked at what happens if you just make a minor intervention. What they did is they measured 24-hour urine excretion of sodium and determined what would happen if we just made a modest reduction in sodium intake. And indeed, in this study, all they told their patients was over a 9-week period, there's about 300 patients, stop eating salty bread, have no salt bread, and also get away from the cold cuts, cheeses, and all these really minor things that you could possibly avoid to prevent excess of sodium intake. With that, the average drop in sodium intake based on urinary excretion of sodium, which is really the only way you can check if a patient's really evaluating this, doing the right thing, there was a substantial reduction in blood pressure. This seems very high. This is a short-term study. My only point I'm trying to make to you here is that these patients can have an impact that's quite significant with even modest reduction in sodium intake, even if you can't get them down to that 1,500 or 2,300. You might be able to get them down a little bit. Potassium is important. As I mentioned earlier, you want to have between 3,500 milligrams or to 5,000 milligrams a day. If you can have them eat avocado, squash, whatever, bananas, whatever is their favorite high potassium diet, that in itself can lower blood pressure 5 to 6 millimeters of mercury. So that's a pretty simple intervention. Now let's move on to pharmacologic therapy. Again, any patient who we treat for hypertension, it's not about getting to the drugs first. It's about getting them to try to change lifestyle. We all know how hard that is. And I know I'm preaching to the choir here, but we really have to put the time in to try to make that happen. Now, how do we define hypertension based on these guidelines? There are 4 levels: normal blood pressure, then before I get to that, it's a class 1B recommendation that we should classify blood pressure based on levels of blood pressure. These are the numbers, quite aggressive. Normal blood pressure, 120/80, and elevated blood pressures, with systolic blood pressures, 120 to 129. Think about that for a second. That's elevated. That doesn't mean, I want to get back, that doesn't mean treatment, it means elevated. And that's sort of like if you think of heart failure, and Brian could get up here and talk about this all day long, when we went to looking at stage A, B, C, and D, it wasn't that everyone in the A category was being, class A was being, or stage A was being treated, but it was a recognition that these patients were at risk for problems if you didn't do something at stage A. This is how I compare this with blood pressure. To me, this is my stage A hypertension. It's the point where you're looking, you're not saying medicines have to be on board, but we should keep an eye and do something early on instead of waiting until there's a problem. And I'll show the epidemiology data that supports that. With this guideline, elevated blood pressure, as I already mentioned, then you have stage 1 and stage 2. What used to be stage 2 hypertension was, what used to be stage 1 hypertension, which was 140/90, is now stage 2. So everything has been shifted. The guidelines suggest that we check on 2 separate appointments, average those blood pressures before making a decision, unless they have stage 2 hypertension, where you might have to be a bit more aggressive. But it should not be made based on one single setting unless it's extremely high and we have reasons to be concerned.
Dr. Gillespie,
Yes.
do you want to check that second blood pressure pretty quickly, like within a month?
Okay, that's a very good question, and I'll go through that in a moment. It depends on the level of hypertension, but certainly you do want to check it in the office, first of all. If it's high, maybe go out. What we do in our office, we have the nurse leaves and comes back sometime later and recheck it. Hopefully the patient has settled down, and often that blood pressure is lower. And if they don't leave the office, if it's still high, they'll come back later and check it, or I'll check it when I go in to see the patient. But the answer to your question is yes. If you're concerned, it should be within 1 month. I'm going to go through the questions regarding is lower better. Now, first, the epidemiology data. This is a very old study that was published in Lancet in 2002. Over 1 million patients were looked at, 61 prospective studies, and looking at what impact does hypertension have on our population. This is the old Lewington data that many of us have heard, maybe not specifically in that way. And what it showed was that all the way down to a blood pressure of 115/75, cardiac event rates were higher at blood pressures above that blood pressure. So while it's an epidemiology study, it just a point that lower blood pressures in the population, people with lower blood pressures do better. The same thing, this is that number that many of you may have heard, 20/10, you double your increased cardiovascular risk. If you have a systolic blood pressure of 20 millimeters over goal, for every 20 millimeters of increase in blood pressure, or 10 diastolic, you double your cardiovascular risk. So it's impactful to have blood pressures that are outside that range. And many of you are saying, well, wait, Dr. Gillespie, I know the data. I know about that Accord trial. The Accord trial was a group of diabetic patients where there was 4,700 patients, and they looked at diabetic patients at high risk to determine if you compared a systolic blood pressure of 120 to 140, what would happen. The endpoint here was composite MI, stroke, and death. Guess what? There was a 21% reduction in stroke, but overall, there was no difference in a composite outcome. Furthermore, one of the things that was positive in this study was that if you took patients and you controlled their serum glucose in a standard fashion and had an aggressive blood pressure with a blood pressure of 120, they had a 30% reduction in event rates. But it did not meet its primary outcome. Remember, when you look at studies, you have to be careful when you start looking at other endpoints. The most important point to be made in the Accord trial, it did not show a reduction in a diabetic population. So then comes the SPRINT trial. This is the hallmark study of over 9,000 patients looking at 120 versus 140. Patients were randomized and they had to have over age of 50 with risk factors. And these patients, they had a substantial improvement in outcomes. In fact, It was stopped early at 3 years because of the high incidence of cardiac events in this group. There's a third reduction in cardiovascular events and also a 25% reduction in all-cause mortality. This came with some increase in syncope. It came with some increase in creatinine, but none of those were morbid events. So if you're looking at outcomes, this has become the thought of study that has been a landmark for non-diabetic patients. Now, how can we explain the ACCORD trial? A couple of things. When you do a meta-analysis of those two studies, there is a substantial reduction. Also, the population number in ACCORD was 4,700. In SPRINT, it was 93. So the population size, if you look at the tracking numbers in ACCORD, if you had a larger population, again, we're kind of looking at data backwards. I'm not suggesting we should do that, but the point is, though, that it was probably underpowered to show a difference. Whereas when you got up to the SPRINT numbers, you had a power that will allow you to do that. Other data, there was a pooled study not including SPRINT, a meta-analysis where the average blood pressure was 133/76. In that group of patients, there was a substantial reduction in mortality. And several other meta-analyses have shown the same thing. A very recent study that was published by by Bundy and his colleagues, which is referenced down below, showed that in 144,000 patients, there was a linear relationship of blood pressure down to 120 in terms of reducing event rates. So there's a lot of data out there in higher risk populations. We don't have the same data in low risk populations, so we don't know the one risk factor person whether this data applies, but certainly in the population that many of us see, the data does appear to show that lower is better. All right, let's move on to how to do this. I'm going to run through this fairly quickly. It's not as complicated as it looks. These things can get very boring, and I don't want to bore you. One of the things that I want you to know, though, is that if these areas, of course, you don't treat with medications. Normal blood pressure, you just continue with optimal care. Hello, ladies. In blood pressure that is mildly elevated, that's where a class 1 recommendation is just a non-pharmacologic therapy we talked about and reassess in 3 to 6 months. Annette, in answer to your question, this is how we look at various stages of blood pressure. First of all, in that patient that has a blood pressure of 130 to 139/80 to 89, that's stage 1 hypertension. In those patients that have a 10-year atherosclerotic risk score of greater than 10%, now you all know this score when it comes to looking at lipids, where the number for lipids is 7.5%. In those patients, you treat with lipids. The same principle, and the guidelines clearly have data to go this. I can't go through everything that shows that validates this model. And the bottom line is it's a class 1 indication that in those patients that have a 10% risk, you should do pharmacologic therapy and non-pharmacologic therapy. Once you get to stage 2 hypertension, treatment is necessary. This group of patients, as we go to the next page, you reassess in 3 to 6 months for stage 1, and then for stage 2, which would be the higher pressure, you do it at 1 month until you get at goal. Okay? And as you'll see later, many of these patients require more than one medication to treat their hypertension. An important point is, yes, the incidence of hypertension goes up substantially from 32% to 46% when you use this new guideline. But the key I want to make here is that when you compare this to JNC7, the number of patients that require additional medication is only 0.3%. And this is based on the National Health Examiner's nutrition study from 2011 to 2014, and applying the data to that subset, the increase in use of hypertension drugs was only 0.3%. That's important because everyone was getting in an uproar that somehow we were going to be using all this extra medicine. It's really about prevention. It's about getting in there early and talking about it before there's a bad outcome, just as in patients that have early hypertension for heart failure. When you don't treat the heart failure, you treat the hypertension. My family and I were at Omaha Beach just this past summer. Very interesting in Normandy, where we landed in 1945, as we mentioned earlier, and 1944, I should say. This is Ike getting the troops all ready to go to Utah Beach, which is next to Omaha Beach, just before the invasion in 1944. D-Day. Why do I show you this? Well, Ike, our president, right after the war, of course, he had a left ventricular aneurysm. He had a stroke while he was in office. Many of us, of course, I didn't know it, I wasn't born yet, but many people didn't know that. But he had significant disease. In fact, Paul Dudley White, who was a Harvard cardiologist and many of us consider the father of preventive cardiology in medicine, he was his personal physician. He had a lot to do with the issues related to JNC7 and all the things we talked about earlier. He privately told Eisenhower not to run for president. By the way, I had to talk about Eisenhower because I talked about a Democrat earlier with FDR, so equal time for everyone here. I know San Diego's demographics. All right. So anyway, Ike was told privately that he should not run for president, but publicly he did. He decided to run again. This was his blood pressure when he got older. He had blood pressure issues for many, many years. You see spikes everywhere, up to 200, diastolics up to 120. He died of ischemic cardiomyopathy about 15 years after that initial event that I told you. He had on autopsy a pheochromocytoma that was never detected. We did have the means to detect it, VMA, metnephrines back then, but it was never checked. Documented in 1930, he had hypertension, and this is all published in the American Journal of Cardiology. So pheochromocytoma, which went undetected, probably played a role in his life and death. I bring that up as we move into secondary hypertension. I'm not going to go through each of these. I want to make a couple of points. When someone comes to your office and they have hypertension and they are on non-steroidal drug, inflammatory drugs, or if they're drinking alcohol, certainly you want to encourage them to discontinue those because that in itself might be enough to deal with the hypertension. If you have abrupt onset or a young patient, someone under the age of 30, you have to consider this as a possibility. Resistant hypertension we'll get to shortly. And the last thing I want to point out, if you have onset of diastolic hypertension in elderly people, remember most of our elderly people have lower diastolic pressures and high systolic pressures. But if they all of a sudden develop diastolic hypertension, you have to consider is something else going on. Obviously, not enough time to go through all of this, but I want to make a couple of points. Renal vascular disease. One of the things when I was a resident, we always screened for renal arterial stenosis because we thought we could treat it and make it better. The data shows us that there's no data yet to show treating renal artery stenosis improves outcomes. There are 3 situations that you consider doing renal artery angioplasty. 4 actually. One situation would be worsening kidney function. Despite therapy, you just can't, so you have to treat that. Heart failure, that's persistent and rampant, that one is unable to treat. And malignant hypertension where you just are unable to control the blood pressure. The other is fibrodysplasia. Non-atherosclerotic causes would be another reason to treat renal artery stenosis. Keep obstructive sleep apnea in mind. The guidelines cannot give a strong recommendation as it relates to hypertension because if the one large clinical trial that looked at obstructive sleep apnea did not show an outcome benefit for the treatment of hypertension, average drop in blood pressure, 2 millimeters of mercury. But we all know we should still screen for it because all the other stuff it does, but not necessarily with the idea that it's going to improve outcomes from hypertension. We talked about drugs and its impact, and all of these are very uncommon causes of hypertension, such as what Ike had.
Bob?
Yes?
In regards to sleep apnea, have they looked at gradations? I guess there's someone who has sleep apnea as an age I have 7.
Yes.
There's someone who has an age I have 70, and they're clearly not the same. And we
You're
see
right.
that anecdotally is that you'll put someone, and yeah, maybe the person, you put them both on therapy if they'll comply to it. And the person with an age I have 7 might only have that 2 or 1 millimeter drop of blood pressure. And we know their mortality trajectory is benefited for a whole variety of other reasons.
Right.
But the person with the age I have 70, their blood pressure goes down like 15, 20 points, and we see it a lot.
I've seen it too. I agree with you 1,000% that if you're looking at, I'm trying to find that water I had somewhere, but if you look at groups of patients, thanks,
Yeah.
Thank you. It's specific, I've had the same thing, Hirsch. I would agree that We probably have to look at that a little bit closer in certain subsets, but if you look at the studies that have been done, to date, we show only a very minimal reduction in blood pressure. And those studies had moderate to severe obstructive sleep apnea in that group. But that doesn't mean it doesn't improve outcomes, it's just the issue of hypertension. I want to talk very briefly about primary aldosteronism, because we miss it a lot. If you look at your patients with, oh, thank you, I have it done, thanks. If you look at patients that have resistant hypertension, what's that definition? Greater than 3 blood pressure medications. We'll talk a little bit about that later. Those patients should be screened because 20% of them have primary hyperaldosteronism. You look at all the increases in AFib, heart failure, stroke, all of these things are increased with primary aldosteronism. So we should consider that in the right populations. And don't ignore if you find an adrenal tumor incidentally on a CT scan, because quite often that could be the cause of that patient's hypertension. What was the third question? Is one drug better than the other? One of the things that's come up over and over and over, it's about the number. It doesn't matter what drug you use if you're getting the blood pressure down. There's been no data to support otherwise. Now, clearly we use guideline-directed medical therapy for specific conditions, but in terms of hypertension, it's the number. Back in 1947, we didn't have much to deal with. All they had were mercurial diuretics, little digoxin, some nitrates, some morphine. Truman had heart failure. He was treated with Dig and it helped him. He didn't have hypertension that we know of, but mercurial thiazide diuretics were used to treat his condition. Fortunately, now we have a lot more. The drugs that have been shown to be equivalent in terms of hypertension outcomes, diuretics, thiazide diuretics. I want to point out of the thiazide diuretics, chlorthalidone has the largest benefit over hydrochlorothiazide. If you look at calcium channel blockers, ACEs, and ARBs, you'll notice that beta blockers are not here. And the reason is that because beta blockers and alpha blockers are less effective in decreasing mortality. So they've been taken off the primary list for garden variety hypertension. Chlorthalidone, believe it or not, in the ALHAT trial, which is the seminal study of over 41,000 patients that was published many years ago, showed that chlorthalidone was superior to other drugs in preventing onset of heart failure, even more so than ACE inhibitors in that population. ACEs were less effective in preventing stroke, but overall these drugs were equivalent in terms of their ability to look at overall mortality. So any of these can be first-line therapies. Avoid using ACE and ARBs together. Remember that, I see that still on the chart sometimes because for hypertension, it increases and causes harm. So based on multiple studies, I listed a couple at the bottom, we try to avoid doing that. We all know that in heart failure with reduced ejection fraction, HFrEF, that we use ACE inhibitors first or an ARB, a beta blocker followed by spironolactone or pleuronone, and now we have sacubitril valsartan that we're using. But what about in heart failure with preserved ejection fraction? We know that hypertension is the #1 cause of this condition, by far. We also know that you improve hospitalizations, cardiovascular disease, and other endpoints if you treat the hypertension in patients that have this condition. Many of my patients who have this do have significant hypertension. We have to be aggressive in getting that blood pressure down to 130/80. The first job is to get the volume status corrected with diuretics, and the second job is use basically the same medicines that we use for heart failure with reduced ejection fraction. This is for the treatment of hypertension, not for the treatment of the heart failure. Let me make the difference, because we have no data whatsoever that these drugs impact outcome when it comes to heart failure. But we do have data that suggests these may be helpful in controlling blood pressure in these patients. The CHARM investigators did show a reduction in hospitalization with heart failure with preserved ejection fraction, but that's not the main point. When you're treating the hypertensive heart failure with preserved ejection fraction, use the same drugs that you would otherwise. Only point to be made on this busy slide is that if you have renal disease, again, target blood pressure is 130/80. If you have albuminuria of greater than 300 milligrams per day, it should start with an ACE. If you're intolerant of ACE, go to an ARB. But if you don't have albumin over 300, you can use first-line therapy with those drugs that we just talked about. Bless you. Quickly, I'm going to go through a few conditions that we should keep in mind, things that may not come to mind to cardiologists or internists right away. And that is when you have patients that have atrial fibrillation, which we seem to have an epidemic in our practice, consider using an ACE or an ARB. The guidelines give that a 2A/B recommendation based on this study that was published in the American Journal of Therapeutics and several other articles where they looked at a meta-analysis of 11 trials and showed that using an ACE or an ARB actually reduced the incidence of developing atrial fibrillation, particularly in patients with left ventricular hypertrophy. So that's a thought. What about valvular heart disease? I spent most of my career being worried about treating hypertension and aortic stenosis with different drugs, like a calcium blocker. Give them a calcium blocker, you're going to drop their blood pressure, and they're going to die on the spot. As it turns out, there's no data to support that. So in patients who have aortic stenosis, we can still be aggressive in treating their hypertension, but do it gradually. There's no data to support your increase in mortality by treating patients with these drugs, but just do it carefully. So again, that's a 1B indication. And also, we want to watch in patients with aortic regurgitation, minimize slowing the heart rate, because you can, in some cases, by doing that, cause worsening heart failure. So try to avoid slowing the heart rate too much in patients that have AR. The last and final question, and I have about, let me leave 10 minutes for questions, is monotherapy or combined therapy? Which is better? I think many people are concerned about starting two therapies at once for hypertension. And the reason they're worried about side effects. The data does not show that. In fact, it's just the opposite, that if you use low-dose therapy, you're more likely, one, to get patients to be compliant, low dose, because less side effects. When you try to amp up one drug, you often get more side effects. After you have that lowest dose of these drugs, they're not as effective as you go to higher doses. So the best way is to attack hypertension in multiple spots. And the data suggests that in patients that have a systolic blood pressure that's greater than 20 millimeters above target or 10 millimeters above target, you should use two therapies right away. And without having increased side effects, just the opposite, you have less side effects. It's reasonable in patients that have stage 1 hypertension to start only one drug and amp up, but we really should change our thinking about using. I remember I brought this up in my division. They thought I was crazy. Why the heck are you guys, why would you do that? Remember Paulo, Liz was, but anyway, this is what the data shows us. Special considerations. This is another controversial point, but I want to remind you that many of our elderly patients are very fit. We have 80-year-old patients that are incredibly fit. Why should we give them a different number than we do a younger patient if they're not institutionalized and able to use the same therapies? We shouldn't. The guidelines tell us that. 1A indication, still use the same guidelines. One point to be made, however, very important, have them check their blood pressure standing at home. Have someone help them stand up or stand up on their own, and make sure they're not getting orthostatic. That's one of our issues that we have to be careful. Elderly people tend to become more orthostatic with treatment, and I think that's when we get in our trouble. And we should check it in the office also. One thing I didn't bring up earlier, we should always check blood pressure in both arms, because quite often you may have subclavian stenosis and you want to use the higher blood pressure because that's the true blood pressure. So always check in both arms, particularly in older patients. The SPRINT trial had a sub-study of 2,600 patients, and they specifically looked at this question. And these patients were not all, some of them were frail, but they were ambulatory, they were not institutionalized. They had the same benefit at the lower blood pressure as the entire group did. So elderly patients who are ambulatory and can do what the normal things, don't change your guideline. Use clinical judgment, of course, in those people who are frail. Racial differences, we know that African Americans have significantly higher hypertension, poor outcomes with renal disease, multiple increased risk in dialysis needs, higher risk of overall event rates. 90% of African Americans who make it over the age of 80 develop hypertension, 80% in the general population. Younger patients, it's rampant. Most importantly, you should use a diuretic or calcium channel blocker in all African American patients as first-line therapy. And remember that in almost most cases, they're going to need double therapy, more than one therapy. So consider doing that fairly early on in this very high-risk population. My last topic I want to discuss is resistant hypertension. Many of the patients that we see in cardiology, this is why they come to us, they just can't get the blood pressure controlled. Again, this was the group we talked about, 20% having primary aldosteronism. To make the diagnosis of resistant hypertension, they have to be on a diuretic, first of all. That's one of the 3 drugs they have to be on. And we want to exclude pseudo-resistance. What is that? The things we talked about, checking the blood pressure incorrectly, patients not taking their medicines, which is a problem. The biggest thing in resistant hypertension is lifestyle modification. Most of these patients are resistant because they have obesity, they are not eating correctly, and all the things we mentioned earlier. So in this group, you have to be very directed in emphasizing that. You want to discontinue any medicines that might be interfering with that. And of course, all of the best drug that you can use, and this comes from the Pathway 2 trial, which is an interesting study looking at resistant hypertension. Every resistant hypertensive patient should be on a mineralocorticoid receptor antagonist, meaning spironolactone or pleuronone. Now, coming to the end, not everyone agrees with these targets. I want to make a point. This guideline is well beyond targets. The American College of Physicians, the American Association of Family Practitioners declined to be involved with the guideline process. They were invited at the very beginning of the process and declined involvement. They made a decision to continue with the JNC8 considerations of 150 over 80 over 90 for the patients over 60, but otherwise continue with those who don't have kidney disease or diabetes, but to otherwise continue with the JNC guideline recommendations. The European Society just came out with their recommendations. Their recommendation was continue at 130 over 80 for high-risk patients, 140 over 90 for others, but to consider getting down to the same guidelines that the US has, that we just talked about. So there's still some concern there and some differences in opinion. Take-home points I want to make. One, I don't like the term essential hypertension. I think it's an attitude that we had about hypertension many years. There's nothing essential about it, and there's certainly nothing benign about it. The term should be primary hypertension and secondary hypertension. Remember that modest reduction in sodium intake can have a major impact on blood pressure outcomes. Just getting people to exercise, a good diet, increasing potassium in the diet, as we mentioned earlier, can make a huge difference. Increasing potassium is an easy one, I think. 2017 guidelines only minimally impact drug utilization. Again, it's about prevention. And all of these drugs are quite similar in their ability to decrease mortality, but we want to look at guideline-directed therapy. So if you have heart failure or other conditions, peripheral vascular disease, et cetera, you want to direct your therapy that's appropriate based on guideline-based therapy. And there is good support that using 2 drugs is often better than 1 in the right patient population. Ronaldo died September 8th, which is tomorrow. It will now be 6 years. Many of us in this room remember him, and we can't let his wonderful way in which he impacted us ever die. Thank you very much.